Welcome to Conversations on Healthcare. This week we welcome Dr. Mary Bassett, Commissioner of Health for the state of New York, on relaxing mask mandates, pandemic's next phase, and racism as a health threat. Now, here are your hosts, Mark Masselli and Margaret Flinter.
Our guest leads the health department in one of the largest and most diverse states in the country. She brings to this role an incredible background on the front lines of health here in the United States and around the world, and has often tackled deadly diseases such as Ebola, Legionnaire's disease, and the threat of Zika, and now, of course, COVID.
Dr. Mary Bassett is the New York State Commissioner of Health. She previously led the New York City Department of Health and Mental Hygiene, and most recently served as the director of Harvard's FXB Center for Health and Human Rights.
Dr. Bassett, welcome to Conversations on Healthcare. We start with the sad news about the passing of Dr. Paul Farmer, a global health champion and founder of Partners in Health. You were a strong ally in these efforts, and so we'd like to ask you for your reflections.
Well, obviously, we're all stunned at this news. Dr. Farmer was only 62 years old. The last time I saw him was in Butare, Rwanda, where he died. At a school of public health that he'd established to offer frontline health, public health training to people from all around Africa. And this was, I don't know how many chapters he'd had, but this was yet another one entering the world of higher education. So he was an incredibly charismatic figure. I think we can credit a whole generation of young people who went into global health because of Paul Farmer. He always was outspoken on the need to protect the well-being of people who have been left behind all over the world. And he even did some work in the United States, although most of his work was in Haiti, Rwanda. I just can't believe it, really. He had 3 children, and I'm just so sorry that we've lost him. He had so much more to give.
Absolutely.
Well, thank you so much for those words, Dr. Bassett. And I will tell you, within our organizations and communities that we relate to, people were just in stunned silence and sadness yesterday at the news. So we share, I think, as a country in the loss of just a tremendous person. I want to turn to COVID, as we always do these days, but to ask you about the latest details about COVID and Omicron in your state. Certainly a place that was probably the earliest to be hardest hit and very hard hit throughout the pandemic. Your state has lifted its mask or vax indoor mandate for businesses. We know the good news is that cases and hospitalizations are way down, but share with us how you think it's going in your incredibly diverse state as well, from very urban to rural areas.
Well, that's a big question. And my time as health commissioner really coincided with the Omicron surge. I became health commissioner on December 1st, and our first Omicron case in New York State was identified on December 2nd. And all of us were amazed at the rapid spread of Omicron. That spike, vertical, became a signature of Omicron. And in New York State, we were clocking in over 90,000 cases a day at the peak of the surge in the first part of January. I'm pleased to say that we've been coming down steadily, and the drop has been nearly as rapid as the rise. We no longer have any hospitals that are under requests to divert elective procedures. And the most recent data show that something between 2 and 3% of people who get tested are testing positive. We've been up tenfold higher at the peak of the pandemic. So we're on the downside of this. And as you know, we have lifted the requirement that all people be masked or vaxxed in public indoor spaces. We continue to recommend masking. And of course, we very much want everyone who hasn't been fully vaccinated to become vaccinated and to get boosted. Our coverage is now at about 75%. That sounds really good. It is really good. The New York State is doing much better than many other states, but we still need to be higher than that to be protected from such a contagious variant. So I can keep rattling off numbers as you like. The group in which we have the furthest to go are children. We've just headed to about a third. For a long time, we were under 30%. We're going up incrementally. So these are children who've been fully vaccinated. But, that still remains low. This is for the 5 to 11-year-olds. It's higher in the older age groups. And so we are still working on encouraging all New Yorkers to get vaxxed, to get boosted, and to wear masks when they're in settings where they are concerned about transmission. We still have masking required on public transport and, of course, in hospitals, nursing homes, and carceral settings. There still remain places where masking is required, but no longer, as you say, in public indoor spaces.
Well, let me pull the thread a little on young people. And you have lots of difficult decisions in front of you. And one that certainly sparks a lot of interest is when do you think the state will be getting closer to ending mask requirements for students in schools? And really, what are the data points that you're looking at? What's going to drive the decision here, and what's the timing on the decision? And any news you want to break today, we welcome.
No, I'm not going to break any news today, but I will say what we have been saying is that we use a number of different metrics. Of course, we use cases. That's the number of people who test positive. And that metric is challenged, I could say, by the fact that we have more and more home tests being performed. The state itself has procured over 90 million tests. We've sent out the door, as of a week ago, close to 35 million tests. So there are a lot of home test kits that people can test themselves. So we aren't capturing as completely the people who are testing positive as we used to. Nonetheless, the direction of cases is helpful, and we consider to see them decline one day after the other. People who get sick enough to be hospitalized, we don't think are subject to those types of biases. And hospitalizations are something that we look at carefully, and those are going down rapidly. The burden on hospitals, I've already mentioned, the extent to which they were very full, we are looking at. So everything we look at is going in the same direction, and that's very hopeful. But compared to our lull in the summer of July, August of last year, we still have 4 times as many people in the hospital now than we had back then. So things are looking really good. The governor has said when the kids come back from school, we'll have them returning with, we hope, having performed home tests because they were sent home with them. And we'll look at all of our numbers and where we stand then and make a decision about masks in schools. So we're looking at a whole array, the extent to which they're all going in the same direction. And I should add one more thing. Speaking of a global health giant like Paul Farmer, that he's taught us that we have to keep in mind the whole world. And of course, we keep an eye out for any other variants. Omicron went very quickly. It was sort of announced to the world on Thanksgiving Day in November. And we had our first case in New York, just shortly thereafter, and the rest we've all witnessed. So we're also keeping an eye on the emergence of other variants. Even if everything's going perfectly for us with Omicron, we would be concerned that we have protections in place in advance of the arrival of a new variant.
Dr. Bassett, it's clear from your comments and no surprise that you're keeping a very close eye on many data streams to inform decision making. I think the whole country has paid more attention to data, certainly than any other public health episode that I recall, from rates of infection to hospitalization to vaccination. But we wondered if you'd comment that New York Times recently reported that CDC, that we also count down for data, hasn't been sharing all the pandemic data that it has with health departments like the one you lead. And this includes data on boosters and hospitalizations and also maybe some of the wastewater analyses that we became familiar with over time. And they've said that the data collection is small and could be misinterpreted, but how helpful would that data be to you? Do you feel like you're getting all the data that you can from the CDC as well as any other national sources?
Well, I hate to be a sort of New York nationalist, but we have a lot of data here, and we have been contributing to the national conversation about vaccine protection. As you know, we have a wonderful group of data scientists who've been looking at the protectiveness of natural infection, meaning getting COVID, and vaccination. We, right before on December 24th, Christmas Eve, we released information about the much more rapid rise of hospitalizations among children in the pediatric population. Even though these hospitalizations are rare, they were going up faster than hospitalizations for other groups. So we have a lot of data. We also have wastewater data. We are collecting it now in 5 counties scattered strategically around the state. I'm not going to be able to list the names of all of them, but we have received funding to extend wastewater surveillance to the entire state. So we're looking at our data, and I have not heard this about the CDC. We all look to the CDC for data and for guidance. But of course, it is true that during this pandemic, states have occasionally had to make decisions that were out ahead of the CDC. New York State has done that, as have other states. And that's because we look at our data and try to decide what's best for the people who live in our state.
You know, you've taken the lead on addressing what's called long COVID. I know NYU Langone got a $450 million NIH grant to really look at it, but New York State has brought together an expert group of researchers, clinicians, social scientists, and other stakeholders to share their expertise and insight on this condition. What do we know now? And the data seems to be a little scary in terms of the effect that long-term COVID is having on people who might have had mild symptoms to start off with, but are facing a whole range of health conditions. What can you share with us?
That's right. And it's really important that you raise this, because there is, especially with Omicron, a sort of sense increasingly that Omicron's sort of not worse than a bad head cold. And we should all stop worrying about getting COVID now that it's the Omicron strain. And we don't know yet whether the Omicron variant is associated with long COVID, but I would expect that it would be. And it's always a roll of the dice to get COVID. We don't want people to get COVID. So we convened a really wonderful group of scientists, clinicians, people living with COVID. One of the things that we are looking to this group to is to try and give us guidance as a health department on what our role might be. As you note, this and the NIH, has the role and the resources to fund big studies, and they're doing that, including in New York State. But a question for us is, what can we add to this? Because it's clear that even when acute COVID is over, there are going to be people who are living with long COVID. And as you've said, it can be people who didn't even have symptoms at all, weren't aware that they'd been infected, as well as people who had mild symptoms, people who were completely fit, athletes. And it seems to be sort of analogous in ways to chronic fatigue syndrome, which has another fancier name. There are hypotheses about what could explain long COVID, but the science is still evolving. I'm happy to rattle on about what the hypotheses are, but there you are. It could affect a fairly large number of people. Some studies suggest that up to a third of people, I find that number hard to believe, may be affected with protracted symptoms after an infection. But it's clear that this is real. It is not in people's heads, which many of the people who have it have encountered skepticism on the part of their healthcare providers. And that's a clear role that we can play, is to endorse the importance of this, of recognizing this syndrome.
And obviously, it has an enormous impact on how one thinks about the healthcare system going forward and the additional demands that will be put on it.
Exactly.
Yeah, and we're going to really appreciate the additional insights on that as well, because we certainly, as Mark alludes, we are certainly seeing that emerge in primary care as a major issue. Dr. Bassett, I think you probably have to spend 24 hours a day focusing on COVID, and then in the other 24 hours a day, keep thinking about everything else that was there before COVID. But,
Sure.
but I wonder if you could share with us the major health issues that you see facing your state at this point in time. I know behavioral health issues are probably right there on the list, substance use, maternal infant mortality, but tell us what you're zeroing in on. And I know you have to be so broad in your focus and thinking.
Well, one of the things about the New York State Health Department that is really kind of unique is that it has real inreach into the healthcare delivery system. So there is all of the things that we consider traditional public health and an important role, for example, in addressing non-communicable diseases, which will remain the leading causes of death as COVID recedes. And so we still have to work on the fact that with the advent of e-cigarettes, we have youth tobacco use, if we conclude them, back up at levels that it was 20 years ago. And we need to address that. We have the problem of unhealthy food and the continued impact of overweight and obesity and diabetes, which in many ways COVID really uncovered the failures of our system to keep people healthy. And of course, these all became what we now call comorbidities. So we will continue to be focused on tobacco control and on tackling obesity and its related conditions. You mentioned maternal mortality, and that, of course, is one of the many conditions which shows a huge racial disparity in the occurrence, that far more likely to have an adverse event as a pregnant person if you're classified as African American. In New York City, this was one of the biggest racial gaps that I ever saw at that time when I was health commissioner, 12-to-1 fold higher risk of death related to pregnancy and delivery for African Americans. That proportion has fallen, but it's still far too high. So yes, we will be continuing to work on reproductive health issues, thinking through how we will respond as a state that has always given women trust in the event of the loss of Roe, where people are working on that right now. And then there's a whole other side of the agency where we oversee Medicaid, which controls the health insurance. That's not the right word, really, but provides the health insurance coverage for nearly a third of New Yorkers, and figuring out how to make the most out of that in terms of population health and how to bring closer together primary care and more traditional public health. So those all remain really the things that inspire me in public health and got me interested in having this position. But of course, we have to be ready for the next emergency. And that's going to be, likely include microbial threats, but also weather emergencies, climate change. Oh, there's so much work to do.
Well, there's so much,
but all of
much.
it, I will bring an equity lens. And that remains the sort of the North Star of my working life as a physician committed to public health.
Well, Doctor, not only are these some challenges, but we're also seeing challenges that I don't think we've ever seen before. Republicans now in other states are using Dr. Fauci in a negative way in their midterm campaign ads. I don't think we've ever seen a public health official positioned as a political weapon like this before. What's your take on this, and what will it mean to the public health profession?
Well, this has been a really difficult period for government public health, maybe public health more generally. It's maybe a year ago, the Kaiser Family Foundation did an analysis that showed that 150 state and local public health leaders had either left their jobs, either voluntarily or had been fired. So there's been a real hollowing out of government health departments because of the politicization of the COVID response. It began during a period when we had an administration that was really embraced scientific skepticism about the role of expertise at all. So it's been a difficult time. Dr. Fauci is a national treasure, in my opinion, and he has, continued to forge into the muddy waters, so to speak, to defend science. And it's worrying, but a lot of this is not about facts. It's about trust. And we have a really big job to do to rebuild the public's trust in public health and government more generally. And as you probably know, Governor Hochul has made it a priority to rebuild trust in the most general sense. And I hope that we do that by telling people the truth, sharing our data, making clear that we will not hide things from people. And I think Dr. Fauci does all that, and it's really regrettable that he's coming under personal attack. He has bodyguards. His family members have to have bodyguards.
Mm-hmm. So sad. But you are a very visible public health leader in your state. I think people look to you for your voice. And one of the big challenges, it seems, during COVID is we always want to follow the science in healthcare and public health, but sometimes we didn't have all the information we needed to know. Just the science wasn't catching up with the reality.
That's right.
On the ground. How just could you share with us, how did you learn to balance the science and the political considerations and the politics with so much going on? It's really kind of a personal question. Do you have an inner core that you sort of work with on crafting the message, or just say, I'm going with the science I have to date. This is what I know. This is what I don't know. Share a little bit about what that journey has been like this year.
Right. Well, you're right. I mean, COVID has really taught us to cope with uncertainty. And part of our problem is that our understanding has changed and the virus has changed. So part of the issue is that people feel like they were told things that have no longer held up. They were told if they got vaccinated, they wouldn't get COVID. Now we know that's not true. We've seen people get COVID more than once who have been fully vaccinated and boosted. And that's related to waning immunity, which we have learned about, and to a changing virus, which unfortunately will continue to change as long as we fail to get vaccine to the whole world. So how do I deal with this? Well, I try to just do exactly what you said. Tell people what we know, what we don't know, what we think we will know, and not talk to people as if they're stupid. People can, I believe, can cope with uncertainty. We all do, right, in our lives, and to sort of act as though we can only share things that are absolutely clear and incontrovertible won't work. It hasn't worked. And so that's what I try to do. I've only been at this for 2.5 months. So I think that it's been a good time for more openness at the department. We have much better lines of communication with New York City than there ever were in the previous administrations. So maybe also seeing, less infighting will help people have a little more confidence in us.
Be a good model.
I hope
Well,
so.
you've only been at that job for 2.5 months, but you have a long history in international
That's true.
health work and your extensive experience working in Zimbabwe on AIDS treatment. There are a lot
Yeah.
of theories about why Africa has been spared from the worst of COVID death
Yeah.
toll. What's your thought about what's happening there, and what can you share with us on that?
Well, the first thing is I think it's true that everybody thought that it would be a catastrophe in Africa. There are no resources. The health systems are very fragile. The vaccine, as you know, has reached a very small proportion of the population. Even in a wealthy country in Africa, South Africa, I don't think more than a third of people have been fully vaccinated. And yet we haven't seen the mortality impact. And we would see that the way we saw it with HIV by looking at the graveyards, literally. I remember going during the height of the AIDS epidemic to cemeteries, and you would just see a line of grave diggers burying one person after another. In the newspapers, the photographs of people in the prime of life who had died, and presumably many of them of AIDS. So we have other ways than the national surveillance systems to see when there are a lot of deaths going on. And we have not seen that with COVID. So I think it's true that we have not seen the feared mortality impact. And what's the reason? Well, one reason may be that people spend a lot of their life outdoors. And it is true that there's less, there's not as many public indoor spaces. Related to climate, related to access, related to what people do for livelihoods. Another hypothesis, and I don't know how we would prove this, is that people get a lot more infections and had a more kind of revved up immune system. I don't know I don't know the explanation. It's a good question. Thank goodness it seems to be true that Africa, which has paid so many high prices. Africa had the worst AIDS epidemic in the world. That maybe with COVID, they didn't pay as much. Ebola, of course, remains endemic in Africa. So I don't have an answer, but there must be one. But it's been really good news for Africa. There are people who think that the Omicron variant may have had the chance to sort of survive in an immunocompromised person and mutate multiply in that person. And that's why we got such an unusual number of mutations in the variant, that it was related to the fact that many people in Southern Africa are living with HIV. So I don't know where that hypothesis stands, but it would be a really good reason to bring the pandemic under control there as well.
Commissioner Bassett, you spoke a few moments ago about the degree to which health equity has really guided your work and your career. We're in Black History Month. The theme this year is Black health and wellness. We spoke about maternal mortality discrepancies. What more is on your agenda specifically about the degree to which structural racism has caused such health gaps between whites and communities of color?
Well, of course, you see these gaps in virtually any outcome. We saw it with COVID. We saw it with Omicron. The Omicron variant, I think many people thought sort of swept like wildfire and affected everyone equally. But in New York State, the hospitalization gap between African Americans and people who are classified as white went up to twofold. So we saw it also with Omicron. And, I think of this as not a single project. You mentioned structural racism, and it's a phrase that practically didn't exist in public health literature and conversation until the past couple of years, and now we use it a lot. But I think it's always worth taking a moment to talk about what we mean by that. And what we mean by that is the ways in which racism works that don't require personal prejudice. They don't either, due to implicit bias or explicit prejudice beliefs. A key example of that is redlining, which, people may say, well, what does redlining have to do with health? And if viewers aren't familiar with this, this was a program by the government in the 1930s as part of recovery from the Depression to make home more accessible to Americans and to guide the mortgage process. They created in over 50 states an idea of sort of credit worthiness of neighborhoods, and routinely African-American neighborhoods literally had red lines drawn around them that deprived them of credit worthiness and made them victims of predatory lending practices. I'm sitting here in Albany, a formerly redlined city, and in the neighborhoods that were redlined so many years ago, the infant mortality rate remains 3 or 4-fold higher than it is in other neighborhoods. So this is an example of structural racism. It didn't matter when you went into the bank office, what the bank lender thought of you, whether they thought Black people shouldn't have access to mortgages or not. If your neighborhood was redlined, you were not getting that government-backed mortgage. And that, of course, had real knock-on effects. Owning a home is a principal source of intergenerational wealth transfer and deprived African-American communities of access to this asset. It was enforced not only by the banks, but by the real estate agents, by homeowner associations that didn't want to see the prices of their houses come down if a Black family moved in. So redlining is an example of how multiple institutions, independent of the belief systems of the particular individuals, work to create a wealth gap, which has translated over time into a persistent health gap and was delineated by race. So when we talk about undoing structural racism, this isn't a small project. But key to it is always first having data. We in New York State are still working on improving our data on race ethnicity. To be frank, the city did a much better job of this. Anyway, I'm eager to continue to work on it. And then we have to look at all of our programs and say, are we targeting them to the groups that need these interventions the most? It won't always be by race ethnicity. In this state, as you mentioned, we have rural communities that are predominantly white, which have really been left behind. And the opioid epidemic, for example, uncovered that.
Well, thank you so much for shining the light on structural racism and also your comments about redlining. It reminds me of one of our heroes, Dr. Jack Geiger, who early on in the community health center movement really said the things that can improve the community are bank lending practices. So thank you so much, Commissioner, for sharing your thoughts and insights. You can learn more about conversations on healthcare and can sign up for our email updates at chcradio.com. Thank you, Doctor, for joining us today.
Thanks so much for having me and for such a wide-ranging conversation.
Yeah, it was really great. Yeah, good. Continued success.
Thank you. Thank you.